Hi, I'm Howard Spence. I'm Eaton County Commissioner representing constituents here in Delta Township. I just wanted to share this video with you, which I took portions of today when I attended an elected officials meeting at the Community Mental Health Authority for Clinton, Eaton, and Ingham County here in the greater Lansing area. And Sara Lurie, the Executive Director of CMH-CEI, had invited a number of elected officials to come so that she could give them an update and status report on some of the important work that's going on in our community relating to dealing with mental health issues of our residents. And this is a very important part of my interest area here. I'm on several committees in Eaton County, where I am Eaton County Commissioner, where I actually deal with some of the same issues that were being discussed today and which are within the purview and authority area of CMH-CEI. Dealing with issues like substance abuse, treatment and prevention, dealing with mental health issues of anger, people who are untreated and are in agony or distress, or even dangerous on our streets, who just basically need to have someone intervene in their lives to help them. These types of issues, and it all boils down to the coordination efforts of organizations like Community Mental Health Authority for Clinton, Eaton, and Ingham County. And today, Ms. Lurie and members of her staff gave an overview of a number of the policy issues and the budgeting and funding issues which impact on the ability of that agency and indeed on government generally here in our Tri-County area to provide some sort of mental health relief to our residents and to our visitors. And so I wanted to share that with you. I took some video of some of the presentation information, and I think that would give each of you who have an interest in this very serious area of government's intervention in our community, it will give you an opportunity to understand some of the problems, the issues that we need to be addressing. And that is particularly important when we look at what our elected officials are doing in this an election cycle year. So I want you to take a look, and if you have questions, feel free to ask those questions to your elected officials at all levels. Today at the Community Mental Health Elected Officials Luncheon, which Community Mental Health sponsored, there were representatives there from the United States Senator's office. There were representatives there from several of the offices of state representatives from the central Michigan area. There were a number of commissioners there from Eaton, Clinton, and Ingham counties, as well as interested people from our school districts and all of our governmental units that are impacted by the mental health issues, the treatment issues of people right here in the greater Lansing area. So I hope that if you have additional questions, feel free to ask your elected representatives about their positions, what they can do or are willing to do or need to do to deal with the mental health issues of each of us as individuals, our children, and those people who are in the streets of our community right around us. So enjoy these brief excerpts from today's luncheon meeting, and I'd also be happy to discuss some of the issues that are raised or discussed in this particular video. I raised a couple of questions myself dealing with some of my concerns about the mental health treatment of people in our community jails, and the funding and things like that were, I think that as a county commissioner, my concerns go with the funding that the state of Michigan is or is not providing to deal with this very serious problem that we all are impacted by. So please enjoy this series of videos, and I hope it's helpful to you, especially in this election year, to understand what some of the public policy issues are that you can impact on if you contact your elected officials. So thank you very much, and I look forward to dealing with these issues and other issues that are really what government needs to be about in terms of protecting our community and providing for a better livelihood and existence for us all. Have a great day.
That we have been selected as one of 18 potential sites to become a certified community behavioral health clinic. That's very exciting. There's still many hurdles ahead, so we're now getting more information in terms of what that might mean and what the commitment would look like. The Department of Health and Human Services will be asking us for additional information to verify some of the things in our application. They will likely be coming on and doing a site visit, and then they'll make a determination on out of the 18 sites if who or if all of them will be written into the state grant that will be submitted to SAMHSA at the end of October to become a demonstration project state. As always, done our best to avoid cutting into our most high level of care consumers who we support with general fund. That's a huge priority for us. And we did, in fact, have a meeting with Department of Health and Human Services just this morning to review with them where we're at in our general fund and to show them the effort that we're taking to maintain services to consumers and to ask for their help and support in the coming fiscal year to implement things that would help us to be able to correct some of these problems in the future. One of those, most importantly, being equity plan that's been in the works for quite a while. This is a statewide plan that would change the current formula of allocation of general funds. We have been, for our population, somewhat underfunded with general fund traditionally. This reallocation plan would be based on population, and we would stand to gain a considerable amount of general fund funding should it be implemented. So we're hopeful that that process may start this fall. So other than that, we appreciate all the support we've gotten from our county commissioners, commissions who have taken on supporting jail services and allowed those services to continue. So we're really trying to do everything we can to not make painful reductions to our consumers.
Services, assessment, screening for voluntary as well as involuntary psychiatric hospitalization. That is available, that freestanding program, 7 days a week, 24 hours a day. And then you've got the main number for crisis services, and then children's services has a specialized service that I'm going to talk a little bit more about. It's not 24 hours a day, it's specialized service after hours. We see children in crisis services, so it's integrated after hours.
So as Chris was saying, all of our consumers have access to 24 hours, 7 days a week crisis services. During the day, many of you may know that we shift kids over to our section, over to our other building at the Human Services building. We have our kids services, and we shift our kids there to do our emergency services contacts there and link them with our service there. And then after hours, they come to this building to our 24/7 team. It creates stress and sort of capacity issues in those systems, as well as people not getting the appropriate treatment that they need. It also creates stress on other systems like law enforcement, who are responding to some difficulties or having to bring people in constantly. It creates stress on our local DHHS offices in terms of child welfare kids that they're seeing, and we can't get them to the appropriate psychiatric facility or the appropriate psychiatric evaluation. So it creates sort of this community crisis in terms of where these adults and kids are not able to get that treatment. Of note, also a challenge to the system is that CEI currently we are not a medical facility, and what's happening with our psychiatric facilities in the state is there are requirements of how we get consumers in. So for example, they need medical clearance before they'll be accepted into a psychiatric facility. What that means is we have to put someone in an ambulance, take them over to the local emergency room, get medical clearance, and then either they have to come back here or they have to go to the psych facility. Meanwhile, while we're trying to find who's got a bed open and can you keep a bed open until we can get that clearance and other needed documentation. So a lot of sort of back and forth as we figure out how to triage what's needed to get them into the facilities and get an opening. That consumer would be linked with. So pretty direct handoff for consumers eligible for our intensive services. So we talked a little bit before about sort of the challenges within the community. I think specific to CEI, I'll review a couple of those and go in a bit more in depth to those as well as have Chris join me for a couple of these. So as we indicated earlier, the volume and intensity of consumers coming in has been higher. The lack of access to psychiatric beds. We are the only, I believe, freestanding crisis services in the state, meaning that people come here to our campus to get that pre-screen or crisis intervention. Our community has found that to be a very helpful, useful, consumer-friendly access point. What that means for us, though, is if we can't find a psychiatric bed, we're often left having consumers wait here for those beds. And so that puts us in, gets us to capacity issues in crisis services and those boarding issues. It also results in some youth and adults who have been sent for medical clearance or may be acting out aggressively to be housed at the local EDs for multiple days while we're working in conjunction with the local EDs to find them a placement. Related to that, we have some at our crisis respite home for kids. We are not able to ever restrain, and while all of us value making sure that consumers have the appropriate safety plan, making sure that we have behavioral modification plans in place so it would never come to that. We also know that youth and adults in crisis occasionally will do unsafe things. And we cannot divert youth or adults to those points of diversion, for example, in our apple tree respite home, if there's any chance that they will be restrained. So for example, if a youth decided I want to run into the road and kill myself or drag staff into the road, we can never, ever restrain. Again, we would never advocate for anyone to be restrained unnecessarily, but we would like, there also has to be some safety and crisis planning around what you do in those instances, because we cannot put youth there who have any chance of being restrained. In those instances, the home actually gets a licensing violation that never ever leaves their record. And so some more advocacy and problem solving around that needs to occur. Chris, do you want to talk about the jail population?
Does that restraint regulation, is that a state regulation?
Yes, it is.
Okay, thank you.
I guess when you come about the jail population, we do have programs, as you know, and very well, in the 3 county jails. And in fact, I think all 3 counties are funding those programs. I don't know, Eric can probably could speak more to if that capacity is adequate. But just in terms of if somebody's sent over to crisis services and they're under supervision or jurisdiction, actually law enforcement or the jail, correctional officers or corrections, they can't be left alone. Again, back to we don't have a secure setting in the sense that we can physically intervene with folks unless there's some imminent danger to self. But we can't behaviorally intervene with folks. We can't contain them physically if they're going to elope, which is a limitation we have. I think that's what was meant by that. So then it requires law enforcement, and I know this is pulling on your resources or corrections to be present with the person. And as that time continues to grow, when we can get somebody evaluated, have a disposition, place them, and time has gone from hours to days. I think we've think the longest we've had a person stay here is 10 days, and which is remarkable because that unit is not at all, wasn't designed to or intended to house folks for long periods of time. Initially, we have some rooms with beds, and they were extended observation beds. The idea being you could hold somebody overnight, and then maybe the next day you have a plan. And if they had a case manager, therapist, psychiatrist, you could get them rapidly in, get them seen, and try to intervene that way. But it's become sort of a really like a sleeping situation. We've had to develop a food service to kind of address people's needs, so it's gone further and further in terms of boarding folks. And you know about the general fund issues we have. In general, we have an inadequate amount of general fund to meet broad community needs, but anybody can be seen at crisis services, and we do see a fair number of folks who are uninsured so that, and have commercial insurance, so that all costs the general fund if they don't have Medicaid. And community perception of crisis services, I guess we'll probably hear that from you today.
I think you mentioned some training opportunities for collaboration with police officers, and that's a pretty important topic right now. Are you already involved in any screening or training with any of the local police departments relating to the likelihood that their new employees or their present employees is going to be better able to interact on a community level with people who are maybe mentally ill or whatever, different?
Let's say we're not doing any current training, are you guys?
No, what's currently happening is new employees go through the current Michigan system for new officers. This is in addition to that. It'll be a select group of individuals who actually want to work with those populations. It's a 40-hour curriculum, so they're there all week long being trained. They'll have a special certification, specification that they're the CIT officer that goes out on call, like when the call comes in, 911, they'll specifically ask for a CIT officer to come to wherever they need to go. So I think they already have some training. This is in addition to that for a specific few.
Thank you.
Is there any of this training being done with EMS as well, as far as pre-hospital? Because unless things have changed, they transport a lot of, and the one that you mentioned about someone, that actually happened at McLaren, where someone ran out in front of an ambulance, a Lansing fire ambulance, and was killed. And so I hope that, again, they respond a lot to these calls as well. So.
We do, I agree. I'm not
They
sure,
have
but
some
I can,
training in their course of their EMS training, but
we can bring that up. We have a steering committee that's happening right now, making sure that we have everybody who needs to be at the table is at the table. So I'll make sure Darren Southworth and I are partnering on this with NAMI and a whole bunch of other folks, but maybe see if Michelle Harper can bring folks to the table because she's with the Tri-County Area Medical Authority. So.